Thank you. Good morning. Just as yesterday, my topic has surprisingly changed in the program. I just realized this morning, so I didn't change my presentation though. I was initially asked to speak about the modes, and I'm going to speak about the modes because it's a very short talk. Because as we know, modes in terms of evidence, we have no data on the modes as we discussed yesterday. We know that there is evidence for invasive versus non-invasive ventilation in certain disease entities. There is data on tidal volumes, there is data on inflation pressures, and there are data on breathing approaches. But there is clearly no evidence of superiority of any one mode of treatment entity over another. Also, I was asked to compare hypotoxic and hypercapnic respiratory failure, and obviously there is no data along direct comparisons between different types of respiratory failure in this respect. So what do we do when there is no evidence? We do the usual. We explore the physiologic rationale. So this was discussed in some detail yesterday. The potential contributors to the pathogenesis of respiratory failure, starting from controllable breathing, signal transfer, the muscle pump, the gas exchange, the cardiovascular system, and so on, not forgetting metabolic demands for gas exchange. The reality is, of course, that most of our patients have multiple problems. We have simultaneously problems in the pump and the control mechanism due to various reasons. Impaired neuromuscular function is, especially for patients require longer-term mechanical ventilation, is almost consistently there, and the mechanics are impaired. Of course, gas exchange is also a problem, and both oxygenation and CO2 removal are normally in those patients we are most frequently confronted with, both impaired. And not to forget the impairment of cardiovascular function and metabolic alterations. The metabolic alterations especially have been frequently overlooked. Let's just face it, application of positive pressure does not solve the problems, unless the problem is a simple atelectasis, which we can just bring open and the problem is gone. Positive pressure is not the solution. Application of this positive pressure has adverse pulmonary and cardiovascular effects, so that in fact the treatment is the treatments are self-limiting. And therefore the focus, not surprisingly, finally has more shifted to maintaining the minimum support while trying to avoid hurting the patient. Let's go bit by bit, a little bit over the physiology. Ventilatory demand, how much we have to ventilate the patient, depends on various issues. Basically, we have three different components. One is the metabolic activity. To a smaller part, the substrate mixture oxidized plays a role. Lung function, control of breathing, especially the breathing pattern, can have an impact on the efficiency of CO2 removal and the control of breathing. And as we know, in most cases nowadays, unless we are using the NAVA, the control of breathing is us. We control the breathing. Just to remind you on the metabolic demands, this is some very old data on longitudinal changes in energy expenditure in intensive care patients. Our patients are usually hypermetabolic, which means that the CO2 production itself is increased and increases therefore the ventilatory demand. So typically in our patients, both of these components are abnormal and they are increased so that the ventilatory demand increases therefore. How much alveolar ventilation is necessary? if you look at any given PCO2 level, the demand in the diseased patient is increased directly in relation to the amount of CO2 being produced. And if you go back to the Bohr's equation, you can clearly see that the ventilation required to maintain any PCO2 is directly related to the VCO2 and the VDVT. Now, let's have a look at what it actually would be as a consequence for our patients. Since the mechanics usually are deteriorated, and we understand nowadays that we should not blow up the lung, therefore, the deterioration of mechanics necessitates reduction of tidal volume. And therefore, it limits also the minute ventilation because frequency cannot be increased as much as one would perhaps think. The VDVT is impaired, CO2 production is increased, and therefore, in order to avoid lung hyperinflation or overdistension, hypercapnia is more or less an unavoidable consequence unless we go to different additional technologies. Now, let's have a look at the magnitude of these changes. What I have done here is I have plotted on the y-axis ventilation liters per minute. They are marked with solid lines for minute ventilation and with dotted lines for alveolar ventilation. Here is PaCO2 in kilopascals. And let's now take a normal person with a CO2 production of 200 milliliters per minute and a VDVT of about 30, which is already slightly above normal. You can see here the two curves for the normal situation. That's the minute ventilation, that's the alveolar ventilation. As we can see, changing the PCO2 with such lungs and such metabolic production of CO2 is no problem. Because these curves are not very steep, you have a wide range, and also changes that you can do have no major impact on the PCO2. You can have almost a minute ventilation until you are getting to clearly hypercapnic PaCO2s. The situation is completely different in the sick patient because here, for example, this is a fairly extreme example, 70% of VDVT, typically in a severe ARDS in a late phase of the disease, we see such VDVT ratios. And a hypermetabolism producing about 300 cc's of CO2 per minute is not exceptional. So when we see now these two curves, you can see that just to maintain a PaCO2 of 10 or 75 millimeters of mercury, you will need to have a minute ventilation of about 12 liters per minute. So trying to maintain a normal capnic condition under these circumstances is virtually impossible. So as I said, if the strategy is lung protective, hypercapnia is an unavoidable consequence. The second limiting issue is, of course, the frequency. I have here just plotted assuming a VT of 500 cc's, fairly large for that kind of patient, but still you can see that the frequencies start to become limiting fairly early. Typically, you can see autopeep developing dynamic hyperinflation, developing at frequencies approaching 30 or slightly above. And here is just a patient example from my own practice where you can see how the CO2 is bound to arise once one is limiting the tidal volumes in order to have reasonable inflation pressures. So, since the PV relationship usually are fairly narrow, the safe range, the frequency is the main tool to adjust the PCO2.
And as we saw in the graphs, attempts to maintain normal PCO2 without a overdistension are therefore unrealistic in severe ARDS, and we are faced with hypercapnia. What about oxygenation? I'll torture you a little bit with the old formulas from the physiology books in a rewritten format here slightly. I have taken the equations for gas exchange, rearrange them a little bit, ignore the dissolved oxygen just to make them a little bit more palatable to look at. And you can see that we can write the equations for arterial saturation, and we can write the equations for mixed venous saturation. They actually look pretty much the same. There are a few differences. The most important thing here is that we can see that the arterial oxygenation is directly related to cardiac output and hemoglobin. You rarely think about it when you adjust your ventilator, that in fact, cardiac output has a direct impact on arterial oxygenation. Why do we not normally see that? It is because normally the shunt is so small. When the shunt is small, cardiac output has practically no impact on arterial oxygenation, but the higher the shunt, the more impact it has, and so does the hemoglobin. The same is true, of course, for mixed venous oxygenation. Also, that is directly related to cardiac output and hemoglobin, which is something we are more frequently, perhaps, thinking about. What is also important is that for both of these variables, the VO2, the metabolic activity, also has an impact. The higher the metabolic activity, the lower are both oxygen saturations bound to be, which perhaps explains, for example, the favorable effects in acute ARDS of keeping patients' muscle relaxed and sedated. Now, let's put this all together. This three-dimensional picture requires a little bit time to look at that. What I have done here are the relationship between saturations, shown red for the artery and shown blue for the mixed venous. Here is the shunt, and here is cardiac output. If you look at these curves, they actually look slightly familiar, because of course they are reflections, they are part of the oxygen dissociation curve. So let's have a look at the relevance of cardiac output. Let's take a cardiac output of 8 liters per minute and decrease it to 4 liters per minute, which is something which you can fairly easily do, especially if you are looking at high PEEPs and high airway pressures and so forth. Now, first of all, please pay attention to the following prerequisite I have here. I assume a fairly low hemoglobin of 100 for such a patient, a VO2 of 250, not major hypermetabolism. And you can see that in order for a patient with a shunt of 50%, as in this case, that in these conditions, the maximum arterial saturation that you have is 80%. You start from 80%, and when you decrease the cardiac output, 2 things are happening. First of all, almost 100% decreases in cardiac output reduces the shunt. So I have taken here, actually based on real data, the magnitude of shunt reduction I would expect. So we are now talking about a shunt of about 40%. And the cardiac output goes down, and you can see that this reduction of cardiac output decreases the O2 saturation from 80 to 70%. Just the cardiac output, even improved shunt. What happens to the mixed venous saturation? You can see the same thing here. But because we are on the steep part of the oxygen dissociation curve, the change is much more substantial. We start about 45% of saturation, and we go down to below 20. So cardiac output for oxygenation is crucial. The larger the shunt, the steeper is the impact of cardiac output. Here I have isolated now the effects of oxygen consumption and hemoglobin. So we have these two solid lines represent SaO2 and SvO2 at VO2 of 250 and hemoglobin of 100. So now let's do an increase of VO2. We stop the sedation, for example, or the patient has pain, or we do a procedure, and the VO2 goes up. Or the patient has a minor reduction of hemoglobin, 17 grams per liter reduction. What we see here is this is now the relationship of cardiac output and O2 saturation. And as you can see, the lower the cardiac output, the wider is the gap between the two, and the more they change when we reduce these two variables. Here I have plotted the changes in shunt the way I had it in the first graph, just isolated. And you can see also here that these changes of shunt do have some impact, but also in these circumstances, the accompanying changes in cardiac output are much more relevant. So if you try to increase the shunt by blowing up your airway pressures, you may well reduce the shunt, but you will actually worsen the oxygenation unless you can maintain the cardiac output. This is not just theory. This is real data. All data from a study about almost 20 years ago when we deliberately increased cardiac output in such patients. These are patients with severe ARDS. Now, look at this relationship. Isn't it funny? What we show here is actually an increase in oxygen delivery correlates with an increase in shunt. So the shunt goes up, but the DO2 increases. That is because these patients have a large shunt, and the cardiac output is the driving factor for oxygen delivery. And to make things more funny or weird, here you can see how in some cases, of course, you have an increased shunt, you can expect that your arterial PO2 would go down. It does go down, but not in everybody. If the cardiac output change is very large, you can even have increases in PaO2 with concomitant increases in shunt because the cardiac output overrides the effect. So, management of oxygenation, what we do, we usually increase the FiO2, we increase the mean airway pressures, but we need to keep in mind that improvement of arterial oxygenation may reduce the oxygen delivery, which is actually more important for the tissues. And as I have shown you, in the presence of large shunt, low SvO2 due to low cardiac output hemoglobin on high VO2 will have a major impact on the arterial oxygenation, and therefore it makes sense to use SvO2 as a guide of oxygenation in these cases when we choose our ventilator settings and modes. We know the adverse events very well. We know that high intrathoracic pressures compromise circulation. And therefore, just as for the CO2, we need to be permissive in accepting arterial hypoxemia so far as the mixed venous saturation is good. Our patients, even if the NAVA will be able to perhaps and hopefully maintain the diaphragmatic function, our patients who go through this disease process are bound to be weak. Measurable signs of critical illness polyneuropathy develop within 24 hours of starting sepsis. And they are not related just or associated with the diaphragm. They are in all skeletal muscles. So you can expect your patients to be weak and to have poor endurance. What to do with that? I think no mode per se can help. I think NAVA has a hope for enhancing the early mobilization while patients still being supported with the mechanical ventilation. My bias and argument is that due to the generalized weakness in these patients, we should not try to be too aggressive in weaning them, because if they lose all their energy in their breathing, they are not able to build up their performance in the rest of the muscles. So our strategy in my unit is we keep the patients in high ventilatory support unless they are really out of the bed. They can walk, and they are still ventilating. This is from my patient monitor, and I just translated to you. The location says the patient is temporarily in garden with his respirator. So it's possible to mobilize sick patients. One mode for all, or one therapy for all. I think first question is always, is there a problem? And if yes, what is the pathophysiologic basis? Select the mode according to the problem. It's not intentionally hidden. I just forgot to make the animation there. It says, I use volume controlled when I control. And spontaneous breathing driven. When possible, I use pressor support. And I'm bound to believe that in the future, I will most likely, in part of my patients, use NAVA. With this, I would like to thank you for your attention.